For talk number 10, we're going to talk about how to deal with durable LVADs on call. So talk number 9 was about percutaneous LVADs placed in the cath lab. This talk is about durable LVADs placed via sternotomies in the operating room. So the basics of these VADs is it is a parallel pump between the LV and the aorta, and they are preload dependent and afterload sensitive. We're going to continue to come back to that very key concept throughout the talk. So keep that in mind. I drew a diagram here of how I think of LVAD flow. So next we'll go to the settings of these VADs. The first setting is RPM, and that is the only set value. It controls how fast the VAD goes, I guess. And then all other properties are determined by the patient physiology. So watts is a measured value from the pump. Flow is a calculated value from power, speed, and hemocrit. And the pulsatility index is a dimensionless ratio of the highest flow through the VAD during asystole divided by the lowest flow through the VAD during diastole. Normal PI is between 3.5 and 5.5, and the general range is about 1 to 10. So PI is, I think, it can be the most useful or the most misleading value. Most of the time, RPM, power, and flow are going to give you the best primary and secondary indicators of what's going on. PI can only give you additional info after you've seen the patient, got labs, imaging, and finally, after you have everything, PI can either point you in one direction or the other, but it shouldn't be used as a primary way to know what's going on. Just because an increase or decrease PI, it can be due to so many different things. It's going to change with LV function, it's going to change with preload, and it's going to change with afterload. So I wrote down here the general patterns of it, but just keep in mind that RPM, power, and flow are going to be the best primary ways to tell what's going on, and a pulsatility index is a good supplement to the above three. Now, some basic VAD troubleshooting techniques that I found work very well. That VAD patients, first of all, have a much smaller reserve, so you have a lower margin of error, and so this is both good and bad. I guess it's bad in the sense is that if you make big moves, you can make big mistakes. It's good in the sense that if you can make small adjustments, see changes in the patient, follow up what those changes are, and then get labs, scan the patient, use ultrasound, chest x-ray, kind of like build your case using data of what you think is going on. So in a way, it makes things easier sometimes, because it's very easy to see clinical changes even with small interventions. And despite the high stakes and the small reserve of these patients, there's really only 4 things that you can do. You can change your volume status with IV fluids or diuretics. You can change their afterload with pressors or vasodilators. You can change the output of the heart through increasing or decreasing the RPMs or adding inotropes, or if it's a surgical issue, you can call it surgery. So despite the complexity of these patients, you don't really have that many decision points, and you can use this to your advantage to hedge your bets well, to make yourself more likely to be correct. That being said, I put this do not miss list early in the talk on purpose, just to point out that these are things that really need to be caught early. They cannot be missed. And that's because these patients decompensate fast, and those things are IV dysfunction, tamponade, pump thrombosis, cannula obstruction, pneumothorax, hemothorax, stroke, LV thrombus, PE, and severe sepsis or severe bleeding. These are things that you can use as a checklist as well. What I found is that if you cover this do not miss a list of things, the odds of anything really bad happening to you overnight are functionally zero. We'll move on to the alarms next. We'll talk about the high power alarm first. And what you really need to know with the high power alarm is this due to transiently increased afterload, like the patient's intubated and they're agitated? Are they valsalvating? Are they in pain? Are they constipated? So is it something like this, like a simple ICU issue, or is it a pump thrombosis? And pump thrombosis is on that do not miss list. It is a surgical emergency. You can always send hemolysis labs. If these hemolysis labs are anything other than extremely abnormal, it's probably not a pump thrombosis. So it's probably just transient hypertension that can be treated by either addressing the underlying cause or by giving it a short-acting vasodilator. Next is low flow alarms, and this is just as with high power, you want to know if it's just a transiently increased afterload versus something bad. A low flow alarm, which you really want to know, is this just simple hypovolemia, or is this something else that could be possibly very, very bad? The best way to deal with this is to give a bolus of fluids, see if they get better, right? If they don't get better after, say, 500 cc's, it's probably need to investigate further. When you look at the device, depending on the power and PI, it can give you clues to what it is. I'm not going to go into it right now. Just know that if you have a low flow alarm and it's not simple hypovolemia, you're going to need to do a more extensive workup with labs, POCUS, chest X-ray, and also looking at the different VAD parameters in order to build your case. We'll talk about high flow alarm next. This is pretty uncommon. I think sepsis usually presents with hypotension or something else, but you could possibly get a high flow alarm too. What you really want to know in a high flow alarm, is it sepsis or is it something else? So you can if the patient has a PA catheter, you can calculate their SVR. If they don't, you can use point of care ultrasound, look at their heart, make sure nothing is off. You can check the cannula, the RV, and the position of the septum. These high flow alarms are more ambiguous than the other alarms, so it should be taken very seriously. So scan their heart, get labs, blood cultures. You want to do a full workup in this situation. Next is suction events, and suction events occur because the LV collapses around the inflow cannula in the apex of the heart. And usually, and this is almost always, a patient is bearing down or they're severely hypovolemic. When this does happen, it can cause arrhythmias and cause decreased flow through the VAD, so it does need to be corrected. Generally, you want to go to the patient. Is it a patient issue? Are they sedated? Are they in pain? Or is it a hemodynamic issue? Did the day team dry them out and accidentally sabotage you? And the best way to check this is to do ultrasound, look at the left ventricle, and see what's going on. It's generally a pretty easy problem to solve once you use ultrasound. And the most important thing with suction events is to make sure, is it a simple preload issue, or is there some type of RV failure going on. Because keep in mind, it doesn't matter how much preload you have if the right side of the heart has failed, right? You're not going to get any LV preload when the RV is down. The other option is that the inflow cannula is too close to the interventricular septum, and you can use ultrasound. You should be able to see that, and this can also cause VTAC, and we're going to talk about this later on. So next, we're going to get to kind of the more clinical aspects of VADs, and we're going to talk about a general approach first, and then talk about common pathology seen. So the first thing that I would say is always go to the bedside of the patient. These are extremely confusing patients, and other patient populations you can automate a little bit more and rely on the nurse or the RT for some simple issues. These are patients who you should always go to see them every time, because it could be literally anything going on. The other thing is, when you see them, always assess confounding ICU issues. So again, patients in pain, are they constipated? Are they sedated well? Did they not get some of their medication? There's other issues that can hopefully be easily corrected. If it's a true problem, the first thing you want to do is gather data. So you want to know what hemodynamically is going on. You want to know lab-wise if the patient is, what their cardiac output is, and if they're perfusing their organs. And I think getting a chest X-ray is helpful to see their volume status, and also using POCUS to look at their left side, their right side, IVC, aortic valve, and if there's evidence of tamponade. These are all going to give you very good data points to then take a step back and say, with all this data that I have, what is a unifying theory that explains it all, right? And generally, these patients, although they can present in complicated ways, there's generally only a couple decision points. So if you focus on those decision points, you can build a strong case. So we'll first talk about hemodynamic issues, and I kind of lump these together in that the first post-op week, there's going to be a lot of adjustments in the patient's physiology to the new VAD, and that's totally okay. I just put this first in that whenever you see things happen, and you always have to ask yourself, is it just the patient adjusting to the VAD and the VAD adjusting to the patient? I think early in their course, you tend to see vasoplegia, cardiogenic shock, and RV failure. Later on, you tend to be weaning the inotropes, diuresing them, and then fine-tuning RPMs and tracking any RV dysfunction to make sure it's not getting worse. So look at their chart, look at the notes. It just might be the patient's adapting to the VAD. It might be kind of, for how complicated they are, sometimes the answer is quite simple. Next, we'll talk about sepsis. And sepsis can be very tricky in these patients because fever and leukocytosis are often absent. Sometimes it will present as an arrhythmia, sometimes as undifferentiated hypotension. It can be literally anything. One of my old attendings used to always joke that no one should die in a hospital without antibiotics, and with these VADs, it's if you're at a loss, start antibiotics, right? It's not going to hurt anybody. Get the blood cultures first, and if you are correct, you save the patient's life, and if you're not, the worst thing that'll happen to them is they're just gonna get 1 to 3 days of extra antibiotics. The other thing that in the initial management that's different for sepsis is that these patients generally do better with conservative fluid resuscitation followed by early utilization of inotropes and pressors. So this is because they're in a constant state of cardiogenic shock. I found that they generally do better starting epi and vaso. That's like a good combination for keeping both their contractility and their SVR high. And the other thing that you need to know about is patients who are chronically septic are at increased risk for neurologic complications, including strokes and bleeds. I don't have a good reason why this happens mechanistically, but it is observed in retrospective data sets. The most common bacteria that causes sepsis is Staph aureus. Second most common is Enterococcus. And the most common gram-negative is Pseudomonas. So if you were going to start empiric antibiotics, a good thing to do is to cover MRSA and cover Pseudomonas. So something like vancomycin is probably your best for the MRSA coverage, and then either cefepime or Zosyn are both good for Pseudomonas. If the patient has like a chronic dry line infection, Zosyn might be better because it has better anaerobic coverage. But again, then this is something where I would check their old cultures and see if there's any antibiotic resistance. It's very common for these patients to be colonized with ESBL or VRE organisms. And so we'll go to hemorrhage next. Patients who have LVADs are at increased risk of bleeding for two major reasons. One is that they're anticoagulated, and the second one is that the VAD impeller itself causes a type 2 von Willebrand's factor deficiency. You generally see thoracic bleeding early after surgery, and when they're readmitted to the hospital, you see more GI bleeding. Overall, the most common cause of bleeding is an AV malformation in the GI tract. You also have to watch for intracranial hemorrhage. This is associated with high RPMs and MAP greater than 90. No one knows why, but it is seen in retrospective data sets. Interestingly enough, INR is not related to bleeding risk. Treatment for this is to hold anticoagulation and then reverse the coagulopathy if it's clinically indicated. One of the big things for VADs is we don't really want to fully reverse the anticoagulation unless it's a head bleed. And this is because we don't want to risk thrombosing the VAD. So again, this is a attending level a conversation at night. If a patient had the GI bleed, how much do you want to reverse them? If it's a bleed in the head, the answer is almost always full reversal. And then next we'll keep going on to embolus and thrombosis. If you have one, it generally occurs in areas of low flow, and this is an LV thrombus, the left atrial appendage, a closed aortic valve with a aortic root thrombus, or the impeller itself. The clots will go to the brain, the guts and the extremities, kind of like VA ECMO. You're going to see strokes, a mesenteric ischemia, and then cold limbs. Over the course of the LVAD patient's life, they have about a 10% risk of stroke. So patients who are chronically hospitalized generally are higher risk. So just do complete neuro exams, focus on focal deficits, and don't be afraid to scan the patient. No one is going to blame you if you have a weird neuro exam and you scan a patient and it turns out to be nothing. Everyone will be extremely unhappy if you miss a stroke. So an extra CT scan is not the end of the world here. All right, and we'll keep going on to arrhythmias. We're almost done. So the first sign, arrhythmias are often the first sign of something else going on. And this is different from other populations of patients. They can be from strokes, hypovolemia, GI bleeds, sepsis, you name it. So don't just correct the arrhythmia and move on with your day. Any new arrhythmia should always trigger an aggressive investigation into some other underlying cause. The most common two that you see are AFib and VTAC. AFib is going to harm both the RV and the LV because the failing ventricles tend to be dependent on that atrial kick for their preload, especially the left side. So you want to give them either usually amiodarone or a beta blocker to try to knock them out of the rhythm. But just keep in mind that you might, you both need to solve the underlying cause and to convert them from the rhythm as quickly as you can. VTAC is the other thing that you see. This is the most common in the first 30 days, and the reason why this happens most of the time is because the inflow cannula touches the interventricular septum. I should say that is one of the bad reasons why. One of the most common is that the patient is just severely volume down. So usually giving them amio, sodium channel blockers, and then solving the underlying cause, especially if it's a volume issue, it's relatively easy to solve overnight. And finally, clinical problem-wise, we'll talk about aortic insufficiency. And so this happens over time because the pathophysiology of this is that the failing LV can't generate enough pressure to open the aortic valve fully. And this creates turbulent blood flow around the valve, which then creates a functional aortic stenosis. And as that turbulent blood flow wears down the valve over time, it leads to a chronic worsening AI. And so why is this an issue, right? Who cares if you're shooting blood through the VAD? Why should you care about the aortic valve? Well, there's two main reasons why we should care. Reason one is that a static aortic valve tends to build up thrombus behind it because blood in the aortic root becomes stagnant. So this is something that can be seen on CT angios and TEEs. It's harder to see on TTE, but it is possible. The other issue is that if the patient develops severe AI, there can be a short circuit of blood in the ascending aorta. And what I mean by that is that blood ejected through the VAD will go retrograde up through the aortic arch and down through the aortic valve back in the LV, and then out of the VAD again. And a portion of the VAD's output will not be going to the body, and this can cause failure over time. So usually this takes at least 5 years to happen, but some of these patients have VADs for 5, 8, 10 years. So the longer you have the VAD, the more likely is this to occur. And the best way to check this is to just do point of care ultrasound. You can also do a CTA. I think it would be highly unlikely to need a TEE overnight. Usually just ultrasound and CTA is going to give you the answer. And then the last thing that we're going to talk about is code blue situations. And the things that you want to know whenever the patient's heart stops is the device working or not. If the device is not working, do full ACS, including high quality CPR. You can do subcostal compressions, have been reported as equivalent to normal chest compressions. Do not turn the device back on, because if there's thrombosis inside of the VAD, turning it back on is going to send a gigantic shower of emboli throughout the body. And this is a situation where the patient will probably have to go on VA ECMO, call the attending, call surgery, rally the troops. This is something that is a attending level and fellow level issue. if the device is working, treat the underlying cause. So you generally don't need to do chest compressions because the VAD is doing already most of the work. So I would do chemical code only, try to convert them out of whatever rhythm that they're in. You almost always don't need to do CPR, and then treat the underlying cause. And that is, we are finally done for VADs.